Hi everyone, this is Lahiri. Welcome to ABCs of Anaesthesia, and I'm with Kaz. We're going to get back into our Basics of Anaesthesia series of medications. And the last one for this series is going to be vasopressors and inotropes, just the common stuff, the stuff you need to know straight away when you're going into work. So let's get started. Hey everyone, welcome again. The usual disclaimer, all of this is just general medical advice. Please don't use it to treat any specific patient. So let's get cracking. Kaz, it's been a while. Happy New Year. How you going?
Yeah, good. So I think the last one we did together was around in September. What's happened since then? We've had a lockdown. We've come out of lockdown. Everyone's got COVID.
Yeah.
I think it's really interesting that whatever we do in this 2-year period automatically is dated by any conversations to do with COVID. So, in 10 years' time, we will look back at this and go, this is during a pandemic.
Should we put some kind of timestamp about the level of lockdown and the level of anxiety, or how few restaurants or places we've been to, or the fact that I haven't traveled overseas in this long.
I think this is the longest I've been in my life since I was in utero when I haven't traveled. So I went to Tasmania over just after New Year's and Christmas, and we went camping and kind of did a few hikes and stuff up in Freycinet.
Oh, very nice.
It was interesting. It was an interesting revelation to me to realize that I didn't necessarily have to go overseas to get the same kind of grounding and perspective that I often go when traveling. That going camping and turning your phones off and spending time with friends is actually enough. So
what you were actually doing was you getting ready for the post-apocalyptic world, and you were getting ready to, as a prepper, you live off the land, camp,
exactly,
hunt for food.
I'm just prepping for the zombie apocalypse, if The Walking Dead has taught me anything.
That's right. Excellent.
How about you? How have you been since last year?
Look, I've got this new camera to help with Zoom quality, which is fantastic. I've spent it's been a really busy time. So a couple of courses now published online, which I'll put some links to. We're going to do a whole series of lectures this year, including, with you as well, Kaz. So medical student lectures and just a lot of stuff in the education space. And I think that's that's funnily the most fun stuff. But yeah, I've got a whole sabbatical planned where I'll do some education stuff with ANZCA in Broome. So that will be really, really interesting. So that's what's happening this year.
Yeah, you finally break the wall into the fortress that is WA.
Yeah, look, I haven't broken into it yet, so who knows if they'll even let me go up to the Kimberley to do these projects. But I can't wait to work in some of those remote centers, and
it'll be amazing.
To work with a GP anaesthetist who are a fantastic bunch there. There's such an active education group as well. Fantastic guy called Casey Parker. He runs a podcast called Broome Docs, I think it is. And anyway, they just have a really interactive, really really involved education process. This fantastic guy called Greg Coates runs GP and anesthetic shoots weekly through the whole year. It's a really great resource to be linking in with those guys. So let's get started with some inotrope stuff.
Yeah, so I guess in this episode, what we wanted to do is cover vasopressors and inotropes. So quote unquote, the uppers that we use intraoperatively and in the critical care space. So I guess let's start really broadly and hone in on it, Lahiri. So what's the difference between an inotrope and a vasopressor?
Yeah, so I mean, the way I think about it, inotrope is anything that increases inotropy, which is your contractility of the heart. And examples of those would be adrenaline would be the major one. And there's all these others that have inotropic effects, like dobutamine. Even noradrenaline at high doses has inotropic effects, and ephedrine as well, one of the common ones used. Now note that this is mainly beta receptor activity. So pretty much any medication that gives you increased beta 1 receptor activity, that will increase your inotropy.
So I guess broadly, inotropy is increasing the force of contraction, and this is due to the intracellular calcium concentration. So as Lahiri said, you can do this via activation of the beta 1 receptors, which are the main agents we use. And then there's other ones that we use more commonly in ICU. So these are things that inhibit phosphodiesterase 3, which is like milrinone, aminophylline, IV calcium itself, and also cardiac glycosides like digoxin. And then levosimendan, which increases the calcium sensitivity of troponins. I know ICU use it a fair bit in different centers in Victoria. I haven't actually seen it used, but that's kind of an overview, but in theater, as Lars said, adrenaline, noradrenaline at high doses, and then ephedrine are the main ones we use. Cardiac, you might use dopamine and things like that, but outside of a cardiac theater, it's unlikely.
Fantastic. Vasopressors, anything that has this alpha activity on the vessels that causes vasoconstriction or venoconstriction. And so the common things you'll hear about are noradrenaline, obviously, but even adrenaline as we get to higher doses, and then metaraminol. So they've got alpha activity, potent vasopressors, and anything that really has this alpha activity. So the common ones we'll talk about today are then noradrenaline and metaraminol, because they're very specific to what we do.
And what about phenylephrine here? Is that something that you use very often in this day and age?
I've only seen it used in one hospital I've worked in, and it was just an option. So I remember someone having this 100 ml bag of saline and injecting whatever dose of phenylephrine in, I think 10 milligrams was the dose, and just extracting it out for each case. So it's mixing drugs between patients, not the worst thing in that context. But in most of the hospitals I've worked, it's always just been metaraminol for the ease of dilution. How about you?
Yeah, I think I've used it once before, and predominantly for obstetrics. I think it's cheap, and again, they used to, I think, they take one vial, diluted it down, and use it between patients. I think there was a bit of a notion that it was, I think it was traditionally used in obstetrics, so I think it kind of persevered in that space. I think there was some notion it's better than metaraminol, but from what I know, they're very similar, and I think metaraminol is, if anything, a bit better. Is that right?
Yeah, that's right. Like all those studies where they're measuring the cord gas profiles based on using ephedrine versus phenylephrine, and phenylephrine was better. But those studies never showed any impact afterwards. So the outcome measures weren't necessarily not necessarily clinically relevant. And plenty of times you'll see people using metaraminol, which wasn't the studied agent, and using it with no adverse events as well.
So staying on vasopressors, one of the things that took me a while to understand conceptually is the actual physiological mechanism by which it increases blood pressure. So traditionally, we know blood pressure equals heart rate times, cardiac output times systemic vascular resistance. So often I just thought, oh yeah, it increases systemic vascular resistance and that increases blood pressure. But one of the things that I think really changed the way I think about this is the idea that these alpha-1 receptors also exist in the venous system. And this venoconstriction that you get with these agents increases your venous return and then your preload, which, depending on where you are in the Frank-Starling curve, can increase cardiac output. And that contributes quite significantly depending on the patient. So if you have someone who's relatively underfilled, then you have quite a pronounced effect. But if you have someone who's overfilled or with significant cardiac dysfunction, in terms of systolic dysfunction, then that effect would be less. And you could even say in someone with severe heart failure, using an alpha-1 agonist would, you wouldn't have that venoconstriction and then increase venous return, and you would have increase in afterload, which is the force that the heart contracts against. So you would actually not see an increase in blood pressure, and you'd actually get a decrease in cardiac output.
Yeah, absolutely. And that's really interesting because you can actually observe this in real time. If anyone's looked at their monitor when they've got an outline in, and often one of the newer parameters that's available is pulse pressure variation. And pulse pressure variation is probably the best evidence-based measure of fluid responsiveness. So if the number is, and the one number to think of is pulse pressure variation of 12, the patient has to, there's a few provisos, can't be in rapid AF or AF in general, has to have a closed chest, minimal PEEP. So there's a few kind of provisos there. And you'll see this pulse pressure variation. If it's really high, the pulse pressure is varying a lot, which means that you're sitting on a lower part of that Frank-Starling curve. So you're underfilled. And if it's less than 12, then you're probably euvolemic or well-filled. And what I notice in those situations where maybe you're underfilled and you give aramine or metaraminol or a vasopressor, then you see the pulse pressure variation trending downwards. So it's almost like, oh, that makes sense. The volume side of things totally is being addressed with venoconstriction with metaraminol. So that's just a little experiment to check out and run with.
That's a really good point. And another way you could apply that is, I think one of the things everyone tells you when you're training is if you have a patient who's bleeding, you need volume, not pressor. And I think it took me really understanding this to understand, well, yes, if you're losing volume and you're losing preload, and you're not increasing that preload with fluid, then increasing systemic vascular resistance won't help. Well, it will help, but it wouldn't be a definitive solution.
Exactly.
So let's put some of these ideas into a clinical context. So the most common clinical situation that we would use a vasopressor in is post-induction hypertension. So what is your framework for approaching this, Lahiru, and what are the considerations that you use?
Yeah, great. So in almost every patient that you'll do an induction, they'll have some level of blood pressure drop, and that's just normal. So the first thing is that if I give propofol and lots of opioids to someone, their blood pressure will probably drop because of venodilation and vasodilation, and maybe even some effects on contractility as well. So, okay, this is a really common thing. Blood pressure drops after induction. What do? The first thing is blood pressure drop could be any of these things: preload, rate, rhythm, contractility, or afterload. And in this situation, it's most likely due to the anesthetic agents. There's it's a very temporal causation type thing. I've given these drugs that dilate the vessels and the blood pressure drops. So my solution to that is to give a venodilator and a venoconstrictor and a vasoconstrictor, or an alpha-1 agonist or an alpha agonist, like Metaraminol, which is, again, really easy to draw up. You've got this vial, 0.5 milligrams per mil dilution, and then you just give 1 mil or 2 mil maybe to just prop that blood pressure up. So that's probably the easiest thing. Now, just remember, you might be wrong about this, and we'll go into this a bit later with the other vasopressors and inotropes. But just remember, if you're keeping on giving vasopressor and it's not working, then you do have to think of that framework. Is it the rate? Is it the rhythm has gone funny, rapid AF, or even VT, or is the contractility bad? But in most occasions, when you have a general anesthetic induction, it's venodilation and vasodilation causing low blood pressure. Metaraminol is the answer.
And a bit of a personal question, Lahiru. How often do you have to use vasopressor after you do an induction? Rarely, most often, commonly?
Yeah, I mean, when I answer this question, I'd say that I often use vasopressor. And I've got to say that this is a funny thing, because I think there's a culture in anesthesia that you feel like giving vasopressor is almost like you did a bad induction. I think when I was training, there's this culture of, oh no, you'd wear that blood pressure, you'd let it drop. It's fine. And it was almost like this thing where the sign of a good anesthetic is not giving vasopressor. But I've got a very counter opinion to that, which is, if you give the right dose of vasopressor to someone who's pain-free and hypnotized, chances are the blood pressure is going to drop, and that's the appropriate response to this. And the right thing to do is to make sure that that map is above a certain range. So I will be far more happy with reasonably liberal use of vasopressor to make sure that that blood pressure is going to absolutely be perfusing the brain. So I don't like this concept of, I'll tolerate a blood pressure of 70 or 80. If their normal blood pressure was 120, I aim, for 20% of that.
And there's a lot of data coming out recently about kind of borderline hypertension intraoperatively and adverse effects that come as a result of that, which I think is very intuitive. But I think you are right. If you're on the ward, you would never tolerate a systolic of 65 and just go, it'll come up. You always treat it. And I think intraoperatively, because we potentially contribute to it with the drugs we use, we often do tolerate it. So I think that's a really valid point. So you should.
Yeah, and there's like the pharmacoeconomic kind of thing as well. Like, it costs a lot to keep drawing up these medications and then breaking them open. So potentially in the past, there was this thing of, we might have to be a bit more, reasonable about where we use these things. But again, yeah, you're right. Data coming out about just don't tolerate sustained hypotension in these patients.
And it's a really weird thing to have as a consideration. The $5 of a drug that you don't want to waste when the surgical equipment itself costs $20,000 prosthesis, for example, in an orthopedic case.
Yeah,
like that cost balance always seemed really weird to me. But I think us as a profession, we're quite environmentally and financially conscious at an individual level, not necessarily at a department level, that we do think about it. And I feel like sometimes I think about it more than I should, especially as a trainee. Yeah.
Again, practical advice: if you're a trainee, you just suggest these things, see what your supervisor says, but just have a look at how often you're using Metaraminol and what people's comfort level is, or what, is there evidence for a MAP or a systolic blood pressure people should aim at. But just know that I think, in my opinion, I'm not tolerating 80 blood pressures of 80 most of the time. I'm always trying to get it above 90 or 100. And if that means running a metaraminol infusion, then so be it. At least I feel like there's very little danger in going or aiming at normality. I feel like there's just something very intuitively right about that. You don't need to aim at absolute normal, but having being able to aim at 20% of normal is, I think, just very reasonable.
Let's maybe extend that a bit more. So as you said, you're giving metaraminol and you're still getting sustained hypotension. Let's say it's a little bit responsive to the drug. At what point do you consider, A, should I start an infusion of metaraminol? B, should you add another agent like ephedrine? And C, when do you upgrade to the big daddy vasopressors like Noradrenaline?
Yeah, you're right. So, I think a metaraminol is beginner's noradrenaline. You can give it peripherally. You don't have to put a central line in. It's very easy to dilute, and it's very common and very easy and practical and very titratable. So first of all, when would I run an infusion? Again, if I'm just constantly giving doses and it's a long enough case, like even if it's a case of an hour, and I'm pretty regularly giving metaraminol, it's just really easy to be hands off. You set up the infusion, run it at 2 to 5 milligrams an hour if that's what they need. You aim at a blood pressure of 20% of their normal blood pressure, and we're good. You don't have to keep dosing it. Also, your anesthetic chart looks a lot smoother because your blood pressures aren't being reactive. Like you actually have a nice constant blood pressure. So in answer to that, I think I would run an infusion if it looks like they're using regular aramine. This often happens in most cases, but there's some cases that I wouldn't, because I know that they're going to start getting hypertensive. So most well patients having laparoscopic surgery, so think of every lap chole you've ever done, initially the blood pressure does fall a bit, but as soon as neuroperitoneum is instituted, generally you have a high SVR state, and you probably won't need to be giving that much vasopressor. Yeah, in terms of when I'd use noradrenaline, usually it's something, either the case is a long case and you'll be using metaraminol for a long time, and there's a certain tachyphylaxis you get with metaraminol because it is direct and indirect acting. So you might deplete some intrinsic noradrenaline reserves. Part of its mechanism of action, it releases noradrenaline from the terminals of the nerves and then causes vasoconstriction. So you might deplete that a bit. So that's why, if I'm doing a big liver case or, Whipple's procedure, these take hours. You put the central line, you might as well start running noradrenaline because that's direct acting.
So that leads on pretty well to another question, which is peripheral versus central Norad. Can you tell us a bit about when you would use peripheral Norad, if ever, and when you would not?
Yeah, I've actually never used peripheral Norad, but I've seen it used. I think in an emergency, you can use these medications with a fast-flowing line. Now, for the audience, the risk with using inotropes and vasopressors peripherally, especially vasopressors, is any extravasation can cause tissue damage, necrosis, and the fact that it's a vasoconstrictor in a peripheral small vein could cause vasoconstriction. But if you use dilute solutions with a fast-flowing drip, it actually may be okay. And I've definitely seen this used in an emergency. So check with your supervisor. Maybe while they're putting the central line in, you'll be dosing metaraminol. Maybe you'll be dosing adrenaline even. And if you really, really need to, dosing noradrenaline peripherally, but very, very, very carefully. And that's an interesting, because I think every single time I've ever needed to give an inotrope without a central line, it's an emergency. And generally, I'll go straight to adrenaline, which is far more comfortable with giving adrenaline peripherally, because they've done that for anaphylaxis, or they've done that for cardiac arrests, or so I haven't actually personally seen the need for noradrenaline peripherally.
I don't think I've ever started either, but I think they do it a lot in ED, in ICU, in emergency care. Not a lot, but I think when needed, yes, when metaraminol isn't working. But I think you have to be cognizant of those risks. And I think cognitively, you then have to go, what's the worst thing that could happen? You could get limb ischemia and lose that limb. And is that better than the alternative? And I think that's kind of the balance I think you have to make. If the patient's peri-arrest and unfortunately gonna not make it through, then I think you can make that call. But I definitely wouldn't do it without a consultant.
Yeah, that's right. So stay away from peripheral administration of NORAD, and be cautious about any peripheral administration of any inotrope, really, especially the powerful ones, adrenaline, noradrenaline, and even metaraminol. When you're running that infusion, if you're drip tissues, that is a problem. So you got to be so careful with all these things.
Moving on to another situation where we would use vasopressor quite regularly is, in an obstetric case. So in a patient under a neuraxial blockade, where we would have to use it regularly. So what agents would you use in this situation for, say, an elective Caesar list? And what are your considerations?
Absolutely. So at this point, you're thinking, why is it every anesthetic needs some kind of vasopressor? Why are we constantly dropping blood pressure? And yeah, spinal anesthetic is one of those very common situations where you take away the sympathetic tone throughout most of the body or a large part of the body, and that causes a decrease in systemic vascular resistance. And that causes your, again, venodilation, vasodilation equals blood pressure drop. So yeah, especially in spinal anesthetics for cesarean sections, this is just such a common pattern that almost everyone would have aramine ready and drawn up. Some cases, general anesthetics, you don't have it drawn up, fit well person having a hernia, but cesarean sections, you absolutely almost always have aramine ready and drawn up. Other places may have phenylephrine, as we mentioned before. And yeah, I think most people either, so what I do personally, I co-load with fluid first, and that's my way of preventing hypotension plus a bit of aramine, whereas other people run an aramine infusion from the very start, give judicious boluses at the start as the spinal goes in, and then as things settle down and the blood pressure starts trending down, you're like, oh good, the spinal's working, the blood pressure's dropping. It's almost a sigh of relief because your spinal's working, and then you start treating with aramine, and running 5 milligrams, or so anywhere from like 2 to 5 milligrams an hour is probably reasonable.
What's the rationale behind doing the fluid bolus beforehand? Is that we're saying it's an issue with systemic vascular resistance, so why are we giving fluid?
So it's it's venodilation as well. So there's an interesting study came out of the International Journal of Obstetric Anaesthesia. They're looking at all the ways that you can prevent blood pressure hypotension during Caesars, and co-load was one of the most effective. And interestingly enough, it wasn't preload. So if you gave it before the spinal, it didn't work as effectively, but if you gave it as the spinal acted and just gave a liter straight up, then it did work effectively. So I'll put a liter on a pressure bag and just drop that in as soon as the spinal's in as my strategy. And then sometimes that's all I need. Other times I do need to give small infusions of metaraminol.
That's quite interesting. I wonder if that's because you do get the movement of the crystalloid out of the intravascular space. So you only get something like 250 mils in a 1 liter staying. So if you co-load it, potentially you get that increase in. Yeah. Yeah. Excellent.
So we've gone through, I guess these are the kind of common things. Having aramine ready is such a common thing. So giving aramine during case is such a common thing. Kaz, have you ever had instances where you're super worried about blood pressure drops and you've already got the infusion started, or you've already drawn up all your inotropes?
Yeah, I think the most frequent is the emergency laparotomy, the sick emergency septic patient. And often if they're above, 65, 70 years old, that hemodynamic compensatory response is going to be blunted. So I think in those cases, you always have usually a big syringe of metaraminol, so 10 milligrams in 20 mils, because you'll have to use a fair bit, or you will have to start an infusion. And there are definitely those emergency cases where you will need to get central access prior to starting the case. You'll get a central line in. And again, even electively, I think those big cases like the Whipple's procedures or any kind of, big esophagectomy, you would really want to have central access before you start. So I guess the broad concepts there are someone you're expecting blood loss, someone you're expecting to be intravascularly depleted preoperatively without adequate time to resuscitate, so an emergency situation, or in someone is going to have crusty autonomic responses, so kind of your sick vascular patients, or anyone who's multi-comorbid with lots of kind of diabetic neuropathy and things.
That's true, yeah. And actually, that's a good framework there, because if you're giving a GA, you're going to drop the blood pressure, and all you have to do is add anything else on top of that, and suddenly your risk of severe hypertension is huge. So anyone who's already got preload issues, septic patient, volume loss, anyone who's got vasodilated, again, septic patient, anyone with any cardiac issues, valve problems, severe stenosis, you're always thinking about this as your major problem of induction, hypertension and poor perfusion. So yeah, nice.
And if you're really worried, you just get a bag of Norad ready preoperatively, and I think you would know the patients you need to have that ready for.
So the next medication that we very commonly use in anesthesia is ephedrine, or what I say, beginner's adrenaline. So yeah, tell us, like, how do you prepare that? What doses do you give? When would you give it?
So ephedrine is predominantly indirectly acting. It has both alpha and beta activity. So I guess that's a similarity with adrenaline. It has both the inotropic and a vasopressor effect. I think there's a couple of preparations that are out there, but the most commonly used one is you have 30 milligrams of ephedrine. So you dilute that down to 10 mils. Some people do it to 5. I do it as a 10 as a standard, so I can do it in the middle of the night when I can't think. So that's 3 milligrams per mil. Now, the key practice points, I guess, about ephedrine is it has both the chronotropic, so increases heart rate, as well as the vasopressor effect. So you actually get both the cardiac and the vascular response. It takes a little while to work. It's not as fast as Metaraminol. So what I got told when I was a junior was it's one cycle of a non-invasive blood pressure. So it's about 2 to 2.5 minutes before you get a response. In terms of dosing, you usually have to give a fair bit, but I think my practice is I always give 3, wait for a response, and then you kind of up titrate as you need to. So 3 to 6 milligrams, I think, is relatively standard dose.
And I found that people can be so variable. Sometimes I give it and you're like, did it even go in? Am I getting a response? And other times, so I ended up giving 3 plus 3 plus 3 milligrams to get this effect. And other times I give 3 and then suddenly the blood pressure is 200. I'm like, well, how did that even happen? Yeah. And I think often it's when someone already has had some aramine and they're primed, and then you add the ephedrine on top of that. Whereas if you just give it straight off as the first agent, you generally need a bit more.
And it's a very common experience, I think, as a first year when you, when the boss, when the consultant leaves the room and your blood pressure drops and you kind of panic a little bit and you're giving a bit of aramine, you give a bit of ephedrine, and suddenly the systolic is 220. You just turn the screen away from the surgery.
Hopefully that wasn't a carotid endarterectomy or a subarachnoid case. No. So and look, I think this is a really good medication for a number of reasons. Like, so the 2 major uses for it. If I'm having metaraminol that's not solving the problem, again, think of the framework: preload, rate, rhythm, contractility, afterload. I'm solving 2 of them, but maybe contractility is the issue. So maybe I really just need to give ephedrine to give that beta effect, that inotropic effect, and that's what's going to be best in this patient. So fantastic. I'm thinking of all the avenues not to persist at a failing task of just giving metaraminol if it's not working. So I give ephedrine, and often that is a solution to the problem. Then I'm thinking, why was there poor contractility? So that's one really good use. And the other one is the fact that you can't give many medications intramuscularly, but you can give ephedrine. So imagine that situation where this has happened a couple of times I've seen, where a patient's being transferred or something's happened and the drip's fallen out on induction or near induction. Patient's hypotensive. And it's always the case where the drip's really difficult. And the way you buy time is, a few things, but one of those things you can give, again, under supervision, make sure there's a lot of other things going on. There's not something just in isolation, but giving intramuscular ephedrine is something that can buy you some time and potentially solve the hypertensive issue while you're trying to get this difficult drip in.
I can't say I've ever had to do that.
It's hairy. When, depending on the situation, it can be very hairy. But this is just, I keep thinking anesthesia, surgery. These are just such high risk environments. There's so many things going on, and these are really good plans to drill and have in place, because there's some really random things that could happen.
And I guess the other practice point about ephedrine is it's a classic example of a drug that undergoes tachyphylaxis. So you get depletion of your noradrenaline stores. So ephedrine has a predominantly indirect action, so it causes the release of noradrenaline. Has some direct beta-1 agonism as well. But the more you use ephedrine, and you see it a lot faster than metaraminol, if you give frequent doses or a prolonged infusion or a prolonged set of boluses, you do get a tachyphylaxis effect. So it's a short-term solution. If that's starting to fail and that tachyphylaxis is showing, then you need to consider another more potent central agent, generally like noradrenaline or adrenaline.
Yeah, excellent. Now, there's a really interesting situation that happens. We do so many lap choles, laparoscopic cholecystectomies, and there's a sequence that happens that can be quite tricky and can cause problems. So there's definitely something that's described as a major problem. So let's say you've done the induction and the patient is hypotensive, and because of the agents and the patient, you've got this pattern of hypotension and bradycardia. And then the surgeon is now about to do insufflation. So at that point, let's say the patient's blood pressure is 70, heart rate's 45, 50, which happens in some inductions with the drug combinations that we use. Now, many people would just go, okay, well, we better give Metaraminol because the blood pressure is low. But I'd almost say that's the wrong drug to give, because suddenly you'll get that reflex bradycardia just as the insufflation occurs. And suddenly you have this situation where you've got a recipe for severe bradycardia or even asystole, which is insufflation of neuroperitoneum causes a Bezold-Jarisch reflex. You've got your baroreceptor reflex causing the bradycardia, and you've got peritoneal stretch causing bradycardia. And this is something that's been described definitely once when I've been working, where a patient had a really, really severe issue happen. But at that point, when you've got bradycardia and hypotension and you're about to insufflate, ephedrine is probably the answer. So you want that heart rate to be above 50 or 60 at least while it's happening. So not giving aramine is probably the right thing to do.
That's a great example, and I think it's a good example of a confluence of factors. But even bradycardia with hypotension alone, I think, is enough of a reason when you should start thinking, should I be giving something that has a bit of beta-1 activity as well?
Let's get on to adrenaline, because I think adrenaline is just one of those amazing life-saving drugs. Maybe we should go again. How do you? There's so many ways you can give adrenaline, and it's used in our practice. And because you've done the first part, you probably know a decent range of things. So let's go. How are the many ways that you can give adrenaline, Kaz?
So adrenaline is a great drug, and I think it's something even as a junior you should be very happy to draw up independently, particularly in an arrest situation, because a lot of non-anesthetic ICU staff don't know how to draw it up correctly. So the ways you can give it intravenously, you can give it intramuscularly. You can obviously do things like nebulize it but that wouldn't really have much systemic vascular effect.
I guess you can nebulize as well for airway swelling, and often we give it combined with lignocaine, so subcut to the vasoconstricted purposes, and we've already talked about it in a local anesthetic lecture.
So what about dosing? So I guess the preparation is quite challenging. So we have and I still don't understand why the nomenclature is the way it is. I think it's just it's the cruel fact of life. We have 1 in 1,000, we have 1 in 10,000.
Yeah.
Teach us your way of conceptualizing the dosing and how you prepare that from both of those solutions.
Fantastic. So the first thing to know is that, okay, let's go with a few examples then. You're worried because you're on the ward or in some context and your patient looks like they're really having a severe anaphylactic reaction. The first right answer for most people who are not an anesthetic consultant or senior trainee is to give IM adrenaline. And the dose for this, for most people, is anywhere from 300 mics to 500 micrograms. So if you imagine that, the easiest way to do it, you've got a vial of 1 in 1,000, which is 1 mil, that's a milligram. So all vials of adrenaline generally have a milligram. 10 mils of 1 in 10,000 or 1 mil of 1 in 1,000, still a milligram. But the easiest way to give an intramuscular dose is take a half of that, so 0.5 mils, that's 500 mics, give it intramuscularly, and that's the recommended standard for anaphylaxis. Now, the proviso, as you become more experienced, more senior, you will be required to give intravenous adrenaline. And this is a risky thing. There's definitely harm that can be associated with it, so don't give it lightly. But we're talking about drawing up doses of 20 to 50 mics, maybe in severe circumstances, 100 micrograms IV. And so, that's tricky to draw up. The easiest thing to do is probably get that 10 mil vial. That's 100 mics, and you can either just take a fraction of that, like 0.5 mils of that is 50, or you can put the 1,000 mics into 1,000 mils of normal saline and then start drawing up doses as you require it. So I think most anesthetists would do the 10 mil thing, label it well, make sure you can't get that confused with anything else on your tray, because that's again how errors happen. and then give it as needed. And definitely when I've had to treat anaphylaxis, I'm getting 10 mils, labeling it well, and then drawing up 0.5 mils at a time to give intravenously.
So the way as Larry said, in both 1 in 1,000 and 1 in 10,000, you have 1 milligram of adrenaline. And the way I think about it is the 1 in 10,000, so the key number there is 10, you have 1 milligram in 10 mils. So I just divide that by 10. So you have 100 micrograms per mil. Mm-hmm. In the 1 in 1,000, it's 1 milligram in a mil. So that's completely neat. And that I think I had to figure out my own way of remembering that, and everyone kind of seems to have a way, but I just remember 1 milligram, 10 mils is 1 in 10,000. And that makes sense to me. As again, a practice point, it's not uncommon, and I would say borderline relatively frequent, that you're in a rest and you ask for, or like your peri-arrest, and you're asking for adrenaline, and someone draws up the 1 in 10,000 straight. And I'm still, actually, it'd be good to get your advice, because you're an ALS2 instructor. It's one of those conversations that's really difficult, because trying to explain how to draw up 10 micrograms per mil, because that's what we are often used to having on hand to give, is really challenging in an arrest situation. And I've progressed now to kind of securing the airway, getting someone else to bag, and then drawing it up myself, just to ensure we get a safe dose.
Yes.
But what's your approach?
Yeah, so that's definitely tricky. To get 10 mics per mil means that I need to get 1 mil of 1 in 10,000. And as I'm going through this, you'll see how complicated this is. There's so many ways that you pass an instruction on and it'll get confused. So I think the easiest thing for people to do is just to give me the 10 mils of your adrenaline and then give me another syringe with another 10 mils of saline, and I can just sort out the dilution myself. But realistically, at the point I'm thinking about adrenaline, I can probably fractionate 1 in 10,000 into enough small parts, because imagine I just 1 mil is 100 mics. I know that with a syringe I can get 0.5 or less and roughly be about right. So if I can probably get to fractions of 20 mics pretty easily, and that stops all the dilutional problems. So that personally, I think that's what I would do. Yeah,
that's good advice, and I guess that kind of brings to light what's the difference between 10 micrograms and 20 micrograms. Probably very little.
Yeah, exactly. It doesn't. Yeah, that's right. And that's one of the reasons why I personally draw morphine neat, because I don't have to really distinguish between 1 and 2 milligrams, and I can draw it up in a 2 or 3 mil syringe, and that's fine. Whereas aramine, you definitely have to dilute, because the difference between giving a fraction of a mil or a bit more of a fraction is a massive problem. So yeah, it's one of those niche things. And so the other way adrenaline is often required and given is as an infusion. And here's a really great little secret to drawing up noradrenaline and adrenaline, which is often we want to run it in mics per minute, anywhere from 1 to 20 mics per minute. So here's absolute gold point that once you learn it, hopefully you'll never forget, is 3 milligrams in 50 mils of a diluent, like normal saline or dextrose. When you run that 3 milligrams diluted into 50 mils at mils per hour, that equals mics per minute. It's just a fantastic thing, because the concentration comes out at something like, if you put 3,000 micrograms in 50 mils, I think that comes out at 60 mics per mil. Yeah, so 3,000 micrograms in 50 mils comes out at 60 mics per mil. And because it's 60, that means that mils per hour equals mics per minute, because per hour is 60 minutes or 60 fractions. So all of that just works. And this is great with noradrenaline and adrenaline. And the extension to that is if you want to use a 100 mil bag of saline, you'd use 6 milligrams in 100 mils. And that's a really easy way to run it. So say I've got a patient who has anaphylaxis. Okay, we've got to start 10 mics per minute straight away. 3 milligrams of adrenaline, 50 mils of normal saline, start the infusion going at 10 mils an hour equals 10 mics per minute.
And I think that's a great trick to have on hand when you don't necessarily have the time or the familiarity to set up an Alaris pump. And if you don't have an anesthetic nurse who can do it very quickly. And I think that's a great way to do it. And I think the clear thing again is, obviously labeling it very clearly, making sure whoever you're giving to a break or your consultant or your juniors are aware that that's what you're doing. Because I think the standard protocol is still, depending on the hospital, I'm guessing it's still running through the Alaris pump, but you don't always have the time to do that.
Exactly. And they'll have different formulas for that. But in anesthetics, we're not worrying about the long-term progress of something necessarily. We need to get something started quickly. So yeah, just this is the easiest formula. Everyone seems to know it, especially in Australian, Victorian, or Melbourne practice. And yeah, everyone knows it.
So I guess let's, something that might be worth talking about, surgical reasons for avoiding vasopressor or for judicious use of vasopressor. Do you want to give us some examples?
Yes, I mean, the major thing that occurs is, I mean, off the cuff, I can think of two situations when you have any kind of transplanting, like a massive plastics case where you've got some kind of free flap. So essentially what the surgeons are doing, they're taking an arterial supply to some kind of tissue and then mobilizing it and resupplying the arteries in a different setting. So really, they're doing some incredible microsurgery to make, say the skin or the muscle in one part of the body transplanted to another part for, any manner of burns or cancer or problem like that, and then replanted. Now that is an incredibly difficult operation. It takes a lot of time, but also the fact that if you use vasopressors, you will start to decrease you'll vasoconstrict that absolutely essential vascular bed, which means that the tissue might have problems taking. And so they really don't want vasopressors running for that reason. So there's a lot of strategies that we'll do for that, including, giving optimal fluid, maybe even running some, beta agonists rather than alpha agonists. But again, you've got this really tricky balance between perfusion of vital organs and perfusion of the free flap. So really tricky balance. And then the other situation is, let's say you've got a patient who's bleeding and the surgeon needs exposure of a site. The common situations are FES surgery, so functional endoscopic sinus surgery. Generally speaking, to get good surgical exposure, you need a hypotensive bradycardic patient. So they will not really want too much aramine being run. In fact, we'll run propofol and remifentanil to decrease that cardiac output just to the right level. But you might have even trickier, bigger cases, emergency cases like subarachnoid hemorrhages, where suddenly the surgeon needs the blood pressure to be lower, and you may be having to tolerate a lower blood pressure for a period of time. Really tricky situation. Lots of talk with the surgeons. Definitely, you'll be having a senior anesthetist there at those points. But so it's essentially avoiding vasopressor, and for the surgical requirement is not an uncommon thing.
What about things like bowel anastomoses and things like that? Is there much evidence around?
Yeah, so that's not like, let's say I've done many bowel resection anesthetics. The surgeons are never too fussed about that. Usually because it's a temporary period of time. And I think it's just bigger vessels. It's not, the vessels aren't as small. I'm not certain about that, but it's never been an issue. I think that if I was running very large doses of inotrope and vasopressor, I'd definitely tell the surgeon that's unusual. But generally speaking, the patients will be off the vasopressor by the time the surgery is finished, so it shouldn't be an issue. Okay, guys, so the final drug we're going to talk about, noradrenaline. So Kaz, tell us about its action compared to adrenaline. Yeah, tell us a bit about that.
So noradrenaline is predominantly an alpha-1 agonist, though at high doses, there can be some beta activity. And I guess this is kind of converse to adrenaline, where adrenaline at lower doses can be predominantly beta, but has a lot of alpha activity at normal doses. So Norad is, kind of the ideal. The vasopressor, as we said before, we want to give it centrally, not peripherally. And it's a very potent vasopressor. So we use it in ICU a lot. And I think in theater, we use it in really unwell patients. I think there's probably a handful of patients I've started Norad on that I've taken off by the end of the case. So it's definitely with the view of continuing it. So I guess, do you want to walk us through, I guess we talked about the preparation of noradrenaline already, Lahira, but do you want to speak to that a bit more?
Yeah, exactly. So imagine you've got a patient who's septic, who's got some kind of vasodilatory problem. Maybe they've had anaphylaxis and now you're trying to treat that. And you're trying to treat the vasodilatory problem of anaphylaxis. So yeah, 3 milligrams of noradrenaline in a 50 ml syringe, or 6 milligrams in 100 ml, run it, mils per hour equals mics per minute. And you'd run anywhere, I've seen some crazy ranges in my time, anywhere from, just 1 or 2 mics per minute up to 20, even 40 in the most sick patients. And really what you're doing, you're treating the vasodilatory state of that. So yeah, and let's say you've got a longer case, like the Whipple's case, you're probably running anywhere from 1 to 5 to 10 mics per minute for those cases centrally. And yeah, you just got to be really careful with these drugs. Extravasation causes tissue necrosis. If you give a bolus accidentally, that can cause severe hypertension. And you're just being really cautious with these medications. But those are the bare bones that you need to know. You'll be supervised. You'll be probably running it through a central line. You'll make sure you can draw it up at the right dose. And then you give it cautiously, and you titrate it and up and down very slowly. Practically speaking, if you're a junior anesthetic trainee, you'll be very well supervised for all of these things. I think the most useful things you can do is suggesting it. So if you're preparing for a long case, suggesting that, maybe we should do a central line, drop some Norad, and having that ability to do the actions like drop Norad yourself, label it, put it into a syringe or a bag, program the Alaris pump. These are all really useful things that, as a junior, I was making sure that I could do all of these tasks, because these are tasks that you want to be able to do yourself as you're learning the more high-end things like putting in central lines and overall management of these situations.
So let's imagine a situation where we are running Norad and we're still quite profoundly hypotensive. And let's assume, for the sake of the argument, that all our alpha-1 receptors are occupied. Is there another agent that we could add on to help with the vasoconstriction?
Again, this is very much ICU territory. So I've never had a situation where I've failed just noradrenaline. By the time it's getting up to that level, I'm definitely calling for ICU input, because they're far more familiar with things. But essentially, I'll maximize adrenaline and noradrenaline. So I'm maximizing vasodilation plus inotropy and chronotropy. So all of those things are covered. And then you've got these extra receptors. So potentially using vasopressin, which acts on V receptors, I think V1 receptors. That can be another thing that you can use, as well as other ways of promoting inotropy and trying to promote cardiac output.
Exactly. So vasopressin acts on the V1 and V2 receptors. So it's a separate mechanism for vasoconstriction to the alpha-1 receptors. So you often commence it when you when you're failing on primary and alpha-1 adrenergic receptor therapy. Again, I don't think I've used it in theater very often, but ICU obviously use it quite often. And then I guess the other things to think about, if you're running a high vasopressor and you can't wean it off, or you're not winning, you then need to think about the other physiological states, like the degree of filling, and make sure you're covering all your bases and not just getting occupied on just using a vasopressor, because sometimes that's not the issue.
I think that's good. We've covered vasopressors, I think, pretty practically. Metaraminol and ephedrine, the common stuff you'll use, just a system for drawing up adrenaline and noradrenaline, how you'd use it in a few circumstances. And hopefully that helps you in your first few weeks of anesthesia.
Fantastic. Thanks for joining us, guys. We'll see you next time. Thank you.
See you next time. Bye.